Usually when we think about anti-aging or, tissue regeneration, the whole process feels incredibly invisible.
Right, it's like a black box.
Exactly. You take a new supplement or you get some cutting-edge treatment and then you just sort of sit around and wait. You hope you feel better.
And you try to convince yourself the money was well spent.
Yes. But you can't actually see the biology changing. Today, for you listening, we are pulling the curtain back on a medical detective story where that invisible healing is finally being put on a screen.
It's pretty amazing. We are looking at a stack of sources today spanning aesthetic gynecology reviews, clinical pilot studies, and some incredibly dense ultrasound methodology reports.
Really dense, but when you layer them all together, a remarkable picture emerges.
It really does. Medicine is moving away from subjective guesswork. We're basically standing at the intersection of advanced diagnostic technology and regenerative therapy specifically, a new therapy involving exosomes.
Imagine a doctor being able to watch your tissue grow younger, like millimeter by millimeter live on a monitor.
It sounds like science fiction, but it's happening.
Our sources detail how high-frequency real-time ultrasound isn't just being used to take grainy pictures of internal organs anymore. It's being used to visually, objectively confirm the cellular rewiring caused by these exosome treatments.
Yeah, the physical thickening of the tissue. But to understand how revolutionary this pairing is, we really have to start with the baseline problem, which is the breakdown of tissue.
Right, the baseline. Where do the sources start with that?
Well, they focus heavily on a widespread condition called genitourinary syndrome of menopause, or GSM.
GSF, got it.
It's this progressive condition affecting up to 90% of postmenopausal women. As estrogen levels naturally decline, the tissues of the vulva, the vagina, and the lower urinary tract undergo these really profound physical changes.
I mean, 90% is a massive portion of the population for an issue that, let's be honest, historically gets brushed under the rug.
Oh, completely.
Huh.
It's treated as just an inevitable part of getting older. It is chronically underdiscussed and undertreated.
So how did researchers get a clear look at this?
To really study how this tissue breaks down at a cellular level, they needed a clear, undeniable model. The pilot studies we're reviewing used a very specific group of patients to isolate this mechanism.
Who was that?
Breast cancer survivors who are taking aromatase inhibitors.
Oh, wow. Okay, I'm familiar with aromatase inhibitors from an oncology standpoint. They basically hunt down and shut off whatever residual estrogen production is left in a patient's body after menopause, right? To prevent estrogen-receptive cancers from growing.
Exactly right. That aggressive estrogen suppression creates what researchers classify as an ultra-low estrogen status.
So it's like an extreme version of menopause.
Yeah, exactly. If scientists want to see the pure, unadulterated effects of estrogen deprivation on tissue structure without any confounding variables, this breast cancer survivor cohort provides the most stark, rapid model of atrophy available.
Let's break down what that atrophy actually looks like physically. Because the sources mention the vaginal wall is composed of 4 distinct layers, but it seems like all the clinical focus is on the middle section.
Yeah, the middle layers are where the action is.
What is actually happening in there?
Well, anatomically, you have the epithelium on the surface. Beneath that is the lamina propria.
Okay, the lamina propria.
Right, which is a layer of dense connective tissue packed with fibrillar collagens and tiny blood vessels. Underneath that is the muscularis mucosae, made of smooth muscle and more connective tissue. And finally, the deepest boundary layer, the adventitia.
Got it. So 4 layers.
Right. And what the data reveals is that estrogen receptors are essentially the foremen of a cellular maintenance crew. When estrogen vanishes, the foremen leave, and the maintenance crew stops working.
So the tissue just stops rebuilding itself.
Worse than that, actually. It actively degrades. The sources highlight a really startling metric here.
What is it?
In the initial 5 years after menopause, a woman can lose up to 30% of her overall collagen.
Yeah.
Wow, 30% in just 5 years.
Yeah. And that loss heavily targets the connective tissue in those middle layers, the lamina propria and the muscularis. They physically thin out and lose their elasticity.
Thinking about this visually, it sounds like a mattress losing its inner springs.
Oh, I like that analogy.
Right, like the surface layer, the epithelium, is just the fabric covering on top. But the lamina propria and the muscularis are the actual metal coils, giving the mattress its bounce, its structure, and its ability to absorb impact.
That's spot on.
If you remove 30% of those springs, the whole mattress just collapses inward. It becomes frail.
The mattress analogy captures the mechanical failure perfectly. The tissue becomes friable, it's easily injured, and highly sensitive.
So how do you fix a collapsed mattress?
Well, the historical bottleneck in treating this has actually been measurement. How does a doctor practically measure a loss of springs inside a patient's body?
I guess that's tough to do. Extremely. For decades, assessing GSM relied entirely on subjective reporting. A physician would ask the patient to rate their discomfort on a scale, or they might do a visual exam and simply note that the tissue appeared pale or lacked moisture.
Or, I assume the alternative would be a surgical biopsy, right? Physically cutting out a chunk of this already frail, irritated tissue to look at it under a microscope.
Which is obviously not ideal.
Yeah, that sounds like a terrible option for routine monitoring. You can't carve out pieces of someone every month just to check if a new medication is doing its job.
No, you can't. It is overly invasive and entirely impractical for tracking progressive healing. The medical field desperately needed a tool that was direct, completely non-invasive, and capable of delivering hard numbers on tissue volume.
And that leads us to the diagnostic breakthrough in the sources.
Exactly. The breakthrough detailed in our methodology sources is the use of transvaginal ultrasound, or TVUS, to precisely measure vaginal wall thickness.
Now, ultrasound obviously isn't a new concept, but the way they're applying it here is completely novel. And there's a specific, fascinating procedural detail in the study that really caught my eye.
The gel.
Yes, the gel. Before the practitioner even uses the ultrasound probe, they introduce 20 cc's of sonographic gel directly into the vaginal canal with a syringe. Why is flooding the area with gel a mandatory first step?
It solves a fundamental problem of physics and anatomy. Normally, the walls of the vagina rest directly against one another. If a practitioner just inserts an ultrasound probe, the probe itself compresses the very tissue they're attempting to measure.
Oh, right, because it's pressing against the walls.
Exactly. Furthermore, sound waves need a clear medium to travel through. They bounce wildly off trapped air or compressed, overlapping boundaries.
So without the gel, the doctor is just squishing the mattress down and getting a distorted reading of how thick it is.
Precisely. By introducing that 20 cc of gel, they create what is called an acoustic window. The gel gently inflates the space, separating the anterior, posterior, and lateral walls without applying any direct pressure to the tissue itself.
That's incredibly clever.
It is. The sound waves can travel through the liquid gel flawlessly and hit the uncompressed surface of the tissue.
It's like filling a deflated balloon with just enough water to see the true thickness of the rubber.
That's a great way to picture it. And the findings from this pilot study, using this gel technique on the ultra-low estrogen breast cancer survivors versus healthy premenopausal women, they are staggering.
Let's hear the numbers. What did they find?
The baseline numbers tell an undeniable story of structural collapse. In the healthy premenopausal control group, the ultrasound measured an average vaginal wall thickness of 4.17 millimeters.
Okay, so just over 4 millimeters for healthy tissue.
Right. But in the severe GSM group, the women on aromatase inhibitors, the average thickness was reduced to just 2.25 millimeters.
So the tissue is basically cut in half.
Cut in half. And across all 4 quadrants of the vaginal wall, the difference was statistically significant. The ultrasound provided a hard, objective number that proved the springs were gone.
Okay, I have to step in here and confess some genuine confusion about the physics of this.
Sure. What's tripping you up?
Well, when I think of ultrasound technology, my mind goes straight to obstetric imaging. You know, you look at a screen and the doctor points to a blurry, grainy gray blob and says, "There's the baby's foot."
Right. The classic blurry ultrasound.
Exactly. If standard ultrasound struggles to show the clear outline of a macro object like a foot, how on earth is a probe reliably measuring a layer of tissue that is only 2.25 millimeters thick? Wouldn't it just be a single, indecipherable gray smear?
That skepticism is completely warranted if we were talking about traditional lower-frequency ultrasound.
So this is different.
Very. The clarity of an ultrasound image is dictated by the frequency of the sound waves it emits. Standard abdominal ultrasounds use lower frequencies, around 3 to 5 megahertz.
Okay, 3 to 5.
Lower frequency waves have long wavelengths, which allows them to penetrate deep into the body to see a kidney, a liver, or a fetus. The trade-off for that deep penetration is a massive loss of superficial resolution.
Ah, I see. You sacrifice a sharp image for the ability to see further into the dark.
Exactly. But with a transvaginal probe, the device is positioned mere millimeters away from the target tissue. Penetration depth is no longer required. So the researchers switched to high-frequency probes.
How high are we talking?
The methodologies in our sources detail using frequencies up to 9 megahertz. And in parallel dermatological fields, like scanning vulvar skin conditions, they use high-frequency ultrasound reaching over 20 megahertz.
Wow. So pumping up the frequency shrinks the wavelength, creating a much tighter, denser net of sound waves bouncing back.
You've got it. The resolution at 9 to 20 megahertz is so exquisite that it doesn't just see a 2 millimeter wall as a single solid line. It can physically distinguish the distinct anatomical layers based on their echogenicity.
Echogenicity.
Right, which is simply a measure of how strongly the tissue echoes the sound wave back to the probe.
The sources actually used some heavy jargon there. They described seeing let me find it, the isoechogenic layer sandwiched between hyperechogenic outer and inner boundaries.
Yeah.
What does that actually look like to the doctor staring at the monitor?
Think of it like looking at a cross-section of a highway. Hyperechogenic means highly reflective. Dense boundaries like the surface epithelium and the deep adventitia bounce a lot of sound back, so they show up on the screen as bright, solid, white lines.
Okay, bright white lines for the outer layers.
Right. Isoechogenic means moderately reflective. The connective tissue in the middle, our lamina propria and muscularis, absorbs more sound, so it appears as a distinct dark gray river flowing between those two bright white banks.
That completely changes my understanding of the technology. The doctor isn't guessing. They can literally see the dark gray stripe of the mattress springs perfectly bordered by bright white lines, and they can measure its exact width down to the fraction of a millimeter?
Exactly. We have successfully solved the measurement problem. We have a non-invasive, highly sensitive tool.
Which is incredible.
It is. But identifying that a patient has a 2.25 millimeter wall thickness leaves us with the harder half of the equation.
Right. How do we rebuild that dark gray stripe back to 4 millimeters?
Exactly.
We need to build new springs. Which brings us to the therapeutic side of the sources and the introduction of a regenerative therapy that seems to be popping up in everything from skincare to orthopedics lately. Exosomes.
That's exosomes.
I read through the sections on exosomes, and I am still struggling to understand the mechanism. Are these just a rebranded microscopic type of stem cell?
That is the most common point of confusion in regenerative medicine today. Exosomes are emphatically not stem cells.
Oh, they're not.
Not at all. They are extracellular vesicles. They are infinitesimally small, membrane-bound bubbles, measuring only about 30 to 150 nanometers in diameter.
Nanometer. So if a regular human cell is the size of a massive sports stadium, an exosome is basically the size of a baseball sitting on the 50-yard line.
The scale is truly microscopic. They are secreted by living cells. And in the context of the clinical therapies we are reviewing, they are typically isolated and derived from human umbilical cord mesenchymal stem cells.
Okay, so they come from stem cells.
They do, but here is the critical distinction. The final exosome product contains no live cells, no nucleus, and no DNA.
Wait, if they're just dead bubbles with no cellular machinery of their own, how could they possibly regenerate collapsed tissue? I try to wrap my head around this, and the closest analogy I could find is thinking of them like microscopic USB drives.
The USB drive analogy is the most accurate way to conceptualize their biological function. A USB drive sitting on a desk cannot process data, it cannot compute, and it cannot build a spreadsheet. It is just an inert plastic shell.
Right, it doesn't do anything on its own.
Its entire value lies in the payload of information it carries inside.
You have to plug the drive into an active computer, and then the computer's hardware executes the instructions contained on the drive.
Exactly. And according to the sources, these exosome bubbles are packed with a highly specific payload: messenger RNA, growth factors, and specialized signaling proteins.
So they are basically the ultimate mechanism for intercellular communication.
They really are. When these umbilical cord-derived exosomes are introduced into the atrophied vaginal tissue, they travel through the extracellular fluid until they bump into the local target cells, specifically the fibroblasts, which are the cells responsible for manufacturing collagen.
Okay, but how does the USB drive actually plug into the fibroblast to deliver the code?
Because the outer shell of the exosome is made of the exact same lipid bilayer as the cell wall of the fibroblast, they operate on a principle of fusion.
Fusion.
Yeah. When they make contact, the exosome bubble literally melts into the fibroblast's membrane. It opens up and spills its payload of mRNA and proteins directly into the interior of the fibroblast.
It hijacks the cell's internal factory line. The fibroblast reads this new imported mRNA code and starts executing the instructions.
That's exactly what happens. And those instructions, in the case of our GSM model, are a massive wake-up call to the maintenance crew.
Tell me about that. What does the cascade look like?
The signaling cascade is dramatic. The exosomes instruct the fibroblasts to proliferate, to multiply their numbers. Then, they command those cells to rapidly synthesize fresh collagen and new elastin fibers.
That's the springs being built.
Yes. Simultaneously, the payload contains angiogenic factors, which stimulate the formation of completely new microblood vessels.
Well, sure, you can't just build new tissue. You have to run plumbing to it so it has the oxygen and nutrients to survive.
Furthermore, they release potent anti-inflammatory molecules that shut down the chronic, low-grade inflammation that typically plagues estrogen-deprived tissue. It is a comprehensive orchestration of tissue remodeling, directed entirely by these tiny biological text messages.
That's amazing. And the sources back this up with some incredible animal models, right? They didn't just hypothesize this mechanism, they watched it happen in overectomized rats.
Yes, the rat models. Removing the ovaries of a rat is the gold standard for simulating human menopause in a laboratory, as it abruptly terminates estrogen production.
Right.
When researchers injected these stem cell-derived exosomes into the severely atrophied tissue of these rats, the subsequent histological analysis looking at the tissue under a microscope was definitive.
What did they see?
They documented profound structural restoration. They saw the rapid assembly of dense new collagen networks, significantly increased tissue thickness, and most notably, the active reversal of fibrotic scarring.
The rat's tissue physically rebuilt its own springs from the inside out simply because the exosome USB drives uploaded the correct blueprint.
Precisely.
This is the moment where the two halves of our research stack collide for you listening. This is the core focus of what makes this intersection so incredibly powerful. We have exosomes, the invisible text messages triggering the connective tissue to rebuild, and we have high-frequency real-time ultrasound, a tool uniquely tuned to visualize and measure that exact type of tissue.
When we look at what the ultrasound is actually quantifying, the synergy becomes so clear. Earlier, we established that the high-frequency waves bounce off the dense outer and inner layers, revealing that dark gray river of connective tissue in the middle.
The lamina propria and the muscularis.
Right. Because the surface epithelium and the deep adventitia are incredibly thin, the vast majority of that healthy 4.17 millimeter wall thickness, or the collapsed 2.25 millimeter wall, is dictated by the volume of that middle connective tissue layer.
So the high-frequency ultrasound isn't just measuring random bulk, it is specifically scanning the mattress to count the springs.
If the primary biological action of the exosome payload is to force fibroblasts to synthesize fresh collagen and expand the vascular network within that specific connective tissue layer,
then the high-frequency ultrasound is the exact right camera to watch it happen.
Exactly.
A clinician doesn't have to rely on a patient coming into the office and saying, I think the dryness is a little better, maybe.
Yeah.
They don't have to perform a painful biopsy to prove the tissue is physically healing.
No, they don't.
The doctor can take the transvaginal probe, use the gel to create the acoustic window, and literally watch the exosome code compiling in the physical world. Over a series of weeks, they can document the dark gray stripe of connective tissue physically thickening, expanding from 2.25 millimeters back up toward a healthy 4 millimeters.
The structural submucosal thickening is confirmed in real time. This provides an objective, millimeter-perfect benchmark to evaluate regenerative therapeutics. It entirely shifts the paradigm of aesthetic and regenerative medicine.
It really does. Historically, these fields face heavy skepticism because their primary metrics for success were soft endpoints, right? Like patient satisfaction questionnaires or vague visual assessments of skin tone.
It is incredibly difficult to justify the cost and effort of a cutting-edge therapy if the only clinical proof is a subjective feeling. But pairing the therapy with this diagnostic tool changes the conversation entirely.
How?
It forces accountability and precision into the process. A clinician can establish a definitive baseline. They can say, your connective tissue volume is currently X. Following the exosome protocol, they can rescan and state, your connective tissue volume is now Y, and here is the high-resolution sonographic imaging verifying the structural change.
That's undeniable proof.
It allows researchers to optimize dosing, refine delivery methods, and definitively separate treatments that work from snake oil.
The ultimate takeaway for you listening is that we are witnessing the death of medical guesswork. We are moving beyond the era of just managing the symptoms of decay into an era where we can actively command the human body to regenerate its own structure.
It's a huge shift.
And more importantly, we now possess the non-invasive, high-frequency lenses required to watch that cellular reconstruction happen with absolute authority.
Moving from symptom management to verified cellular restoration is a monumental leap, and the implications of this synergy extend far beyond the treatment of menopausal atrophy.
Which leads us to a final, slightly mind-bending thought to leave you with today. As we dug deeper into the sources, a secondary application of these exosomes stood out. They aren't just effective at building up thinning tissue, the data shows they are remarkably capable of breaking down severe internal fibrosis.
Heavy, rigid scar tissue.
Right. The sources specifically highlight conditions like Asherman syndrome.
Yes, Asherman syndrome is a devastating disorder where the interior cavity of the uterus becomes fused together by dense webs of scar tissue, frequently resulting in chronic pain and infertility.
Awful.
The early models suggest that targeted exosome delivery can essentially reprogram that rigid, fibrotic scar tissue, signaling the cells to remodel it back into a healthy, pliable, highly vascularized endometrium.
And we also know from our methodology sources that high-frequency ultrasound is already the gold standard for scanning and measuring endometrial thickness.
Right, it's already used for that.
So play this out into the future for a second. If we can use an injection of biological USB drives to fundamentally reprogram deep internal scarring back into healthy functional tissue, and we can flawlessly monitor the entire reversal process live on a high-frequency monitor, could this pairing eventually render invasive internal surgeries for scar removal completely obsolete?
It really challenges the very foundation of how we approach surgical intervention.
Imagine a future where we replace the scalpel with a microscopic text message and a sound wave. Something for you to chew on until next time.